Good evening, everyone. Welcome to today's masterclass. To open the masterclass for today, deliver the welcome address, and introduce the examiners and examinees, I welcome IASO Vice President Dr. T.S. Rao.
Good evening, everyone. I think IASO Masterclass has been a event that has been a torchbearer for the IASO itself, and it has been benefiting both faculty and students over the past few years. I've always been very grateful to the IASO core leadership over 3 years. It all started with an idea mooted by dear friend Derishil Savan, probably one of the best soldiers of IASO ever. And then the next generation of 2 years of leadership that has given us a chance. They thought we should do it, and then I was joined by the very able Sajan Shukla, who has been striving hard to run this program for the past 59 events. This is the 60th one. So it has been a very popular program, and it will continue to be so if we have the cooperation of the IASO and its members, the Executive Council. Today we have a very glittering faculty. What's common between them is all of them are government servants. In these days where there is so much money outside in corporate care and other things, anybody who has become prominent or eminent can go to greener pastures and stay comfortable. But I think these three deserve an applause because they stayed back in government service, and they actually continue to teach students unconditionally and selflessly. We have Dr. Chandra Mohan. He's not new to anybody. He has been the past secretary, very dynamic leader, a star as far as the surgical oncology landscape is concerned. He's from RCC Trivandrum, a very popular teacher, very loved friend, great leader. And then we have Air Commodore Pradeep Jaiswal. I've seen him while we were co-examiners. Found him extremely academic, very affable, very, very knowledgeable. So I've always thought that he should be in the center of all this, because he's in the armed forces. He would not be very active in IASO activities because they keep having transfers, and there is a lot of pressure of work on them. But I think his heart has always been in IASO, so we wanted him to be here. Once again, a very good teacher. I've been to R&R, and then the 3 days that we spent while being examiners, very knowledgeable, very kind-hearted, and then a tough teacher. That is something that I've seen in him, and you would understand that during the course of this event. Caleb Harris, born in a doctor's family, he's always been a surprise for me. Chose to go to Northeast with a missionary's zeal. Just not easy these days, especially for those who are born with a silver spoon. It's much more difficult. He has chosen the path that is less traveled to reach the unreached. Truly appreciate his attitude, and he continues to be in the center of academic activities, being in one corner of the country. He's a core of IASO. He's been a EC member, and we actually hope to see him in higher echelons of leadership in IASO. So all three examiners are wonderful teachers, great government servants, and then very knowledgeable people. I'm sure you'll enjoy the evening. Examinees are Dr. Varun Joshi and Dr. Vajja Sandeep Kumar, handpicked by Sajan, so I know they'll be good. And they'll go through these 3 tough examiners seamlessly. Best of luck, Varun and Sandeep. And I request Caleb to get the event going.
Before we begin, a few instructions for the session to our moderator for today, Dr. Caleb Harris. It will be your duty as the moderator to ensure that both our examinees get an equal opportunity to answer, as well as that all the examiners and yourself address them by their names, so that there's no confusion or communication gap in this online format. To our examiners and moderator, we request you to give the right answers to the questions that are answered wrongly or remain unanswered. This is in interest of all the other participants, as well as the examinees who are there today online, as well as people who are viewing this on YouTube later. To our examinees, please be to the point, and if you don't know an answer, kindly pass it along so that we save time. For the others, the chat box and the Q&A is live, and you can put your inputs there. Let it be the questions, let it be some part of the discussion which has not been discussed, and we'll be sure to include it in the Q&A session which follows the expert talk. With this, I request Dr. Caleb to kindly share his screen and get on with the mock exam. Thank you.
Good evening, everyone, and I want to thank Dr. T.S. Rao, Srijan, and the rest of the team for the kind invitation. So we'll get going with the. My slides are not moving. I'll just stop share and do it again. Yeah. So we have 3 cases for today. We'll start with the first case, which is a 58-year-old lady who presented with epigastric pain for around 6 months. It was mainly, and before that also, she had burning sensation in the epigastrium on and off over 4 to 5 years. She had no other comorbidities, and she has history of chewing betel nut and tobacco for 20 years, which she quit 3 years ago. So the first question to Dr. Varun, looking at the presenting complaints and the history of presenting illness, what do you think? Is there any relevance with this pain in the epigastrium on and off for over 4 to 5 years?
Sir, this is a 58-year-old lady presenting with epigastric pain and burning sensation, which is suggestive of she is having some form of gastritis since the last 4 to 5 years.
Okay, so what is the relationship between gastritis and stomach cancer?
Sir, chronic gastritis, as we know, can lead to metaplasia, intestinal metaplasia, and lead to intestinal type of gastric cancer. Maybe due to the poor hygienic conditions and H. pylori infection, it can lead to gastric cancer.
Okay. Any other points, Dr. Pradeep or Dr. Chandramohan?
Varun or Vajja, I'll ask Vajja. Looking at the history, I think this is the only history Caleb is going to present. Now he's going to examination. Would you like to add some more points, some more questions to the patient to get some more information?
I'll ask, is there any history of vomiting, sir?
Okay.
And I'll ask, is there any history of loss of weight, whether it is significant or not?
Okay.
And I will asking whether he can feel any visible gastric visible peristalsis over his abdomen.
That is too much of a question because patient may not be noticing that. That's a sign, clinical sign. So anything you like to ask the patient, which necessitate, which you like to roll out an emergency situation, something else. So you are suspecting something with upper GI, and you have rolled out there is no obstruction. So which next thing will be worrying you? Varun?
Sir. Sorry, sir. Last question I was not able to understand.
The questions, some questions we like to ask some more questions to get some more information. So,
Yes, sir. I would.
Yeah. So
Ask leading questions. I would ask leading questions, which might lead me to history of gastric outlet obstruction,
Okay.
like vomiting. Whether it is the vomiting is immediately after food or after a few hours, like 14 hours.
Vomiting is already asked. So what else you like to know? So if it is a gas cancer, don't you like to know whether it is obstructed? What is the next thing you like to know?
Sir, whether she is having any history of dysphagia, like if
I'll
she is
cut
having.
it short. So you like to know
What, sir, is
bleeding?
Is anything emergency which can be there?
Sir,
one is obstruction. What else?
Sir, any upper GI bleed or electrolyte disturbance?
Bleed, upper GI bleed. Upper GI bleed. How will you ask whether the patient have an upper GI bleed? What are the two questions you ask?
Sir, I'll ask for a history of hematemesis or melena.
Excellent. Yeah. So please add those two things also, because that is very important in diagnosing and managing this patient if it turns out to be cancer. Sir, Dr. Pradeep, can you carry?
Yeah. So there is Dr. Celeb has told that there is no history of any other cancer in family. So suspecting it to be a stomach cancer, what other cancers you would be interested in? Dr. Varun.
Sir, I would like to ask history of any other family members having a stomach cancer or a lobular breast cancer, any colorectal cancer in the family, or any endometrial malignancies, any other like breast or ovarian malignancies in the family.
Dr. Sandeep, some syndromes you can name associated with stomach malignancies?
Most commonly associated ones are diffuse hereditary gastric cancer, sir. And next are Lynch syndrome, FAP, and Peutz syndrome.
Correct.
And juvenile polyposis.
Most of it is covered. Dr. Celeb.
Yeah, so moving on to the clinical examination, she had a performance status was ECOG 1, and there was no pallor or no supraclavicular node, and abdomen was soft, there was no mass, no hepatomegaly, and on rectal examination, there were no deposits. Is there anything else would you want to see? Or if there is nothing, we can go ahead. So, Dr. Sandeep, what do we see on a per rectal examination? Why are we looking for deposits?
To check any deposits are there, the for knowing peritoneal spread.
Any name for the deposit in the POD?
Commercial deposits.
Is there any other place in the body where else in the general examination, if you find out, what else is there? Other parts of the in the examination, what other named deposits you can think about?
Sister Mary Joseph nodules.
Okay.
Irish nodules and Vacho nodes.
Okay, fine. So there was no finding such in the clinical examination. So we'll move on. So we did the following investigations: the upper GI endoscopy. Yeah, sir. Sorry.
Can you come back? I like to come. Yeah. So, what else you examine in abdomen, Dr. Arun?
Sir, on per abdominal examination, I would like to inspect the abdomen for any visible peristalsis.
Whatever given, they have just given no song. Yeah, excellent. Yeah, what else?
Sir, I would like to inspect for any visible peristalsis, whether it is there or not. On palpation, I would like to see whether there is gastric distension.
Okay. And tell me one more investigation which is used for diagnosing the stage. One more examination, one more finding. Am I audible?
Yes, sir.
Free fluid in the abdomen, sir.
Yeah, one more finding. Excellent. Yeah, you have to examine that. And I'll ask you one question. Suppose, what's the relevance of examining the axle of the patient? Vajja, what is the relevance of examining the axle of the patient?
To know whether there is any Irish nodule, sir, which indicates it is a metastatic deposit.
I think it is better to know some terminologies. And what is a supraclavicle node is called?
Warchow's node, sir.
Okay, what if the patient had a periumbilical nodule?
Sister Mary Joseph nodules.
Excellent. Okay, please go ahead.
So moving on to the investigations, the patient, we got an endoscopy done, upper GI endoscopy. The findings were of reflux esophagitis and a large ulcer in the proximal antrum with irregular margin and necrotic base. The duodenum was normal and the impression was query carcinoma stomach. Biopsy revealed an adenocarcinoma. Patient had a hemoglobin of 12.5 and albumin of 4.14. So what further investigations would you want to do?
Caleb, before going to further investigations,
Okay, relevance of these.
Yeah, I'd like to ask Varun again. How do you take a biopsy from this ulcer? What is the principles?
Sir, I would like to take 6 to 8 biopsies from the representative areas, mostly from the periphery of the ulcer, which is the replicating zone.
Okay, good. And what is the importance of doing a J maneuver?
Sir, if I want to visualize the fundus, whether there is any synchronous lesion, then I would do a J maneuver, sir.
So how do you know which is fundus, which is the greater curve, which is the lesser curve in endoscopy? Yes.
Like, sir, just beside the cardia, while doing the J maneuver, we'll visualize the fundus. On entering, sir, we'll first try to go to the duodenum first, and while coming back, we'll visualize the pylorus, antrum, and then body, and then do the J maneuver, and we'll examine the fundus, and then coming up, we'll examine the GE junction.
My question is the lesser, which is lesser curve, which is greater curve? How do you know that? Because you have to locate it. No? Sometimes the tube may be rotated.
Not sure, sir.
It's based on rugosity. You see rugosity. And again, coming to Vajja, are you happy with the biopsy report of adenocarcinoma? Would you like to have something more?
I want to know whether it is well differentiated, moderately differentiated, or poorly differentiated. Sir.
Why do you want to know that?
My further investigations will be based on that.
Okay. And what else?
Next, I'll proceed to know to stage the disease.
I'll again come back to your answer. So, there are two scenarios. If it is a poorly differentiated carcinoma, well differentiated carcinoma. So, how are you going to differently investigate these two cases?
In case of well differentiated adenocarcinoma, sir, my staging investigation would be a CT, contrast enhanced CT of the abdomen, pelvis, and thorax. In case of poorly differentiated, sir, sorry. In case of well differentiated adenocarcinoma, I can get a PET scan done.
Well differentiated, you want PET scan. Why?
In case of poorly differentiated malignancies or cyanide ring cell carcinomas, FDG uptake is very less.
All poorly differentiated may not be secondary.
Yes.
Correct.
So I don't think we try to investigate it further differently, but there are therapy implications, like in the margin, because I am supposed to tell answers. I'm telling the margin is different in both. So I'll come to that later. So, Dr. Pradeep, sir, please go ahead.
So what will be the next investigation which we like to do? Dr. Varun, once you get this report.
I would like to get done a contrast enhanced CT scan of abdomen, pelvis, and thorax.
Okay.
Yeah. Before that, Dr. Varun, what is the importance of albumin hemoglobin here?
Sir, patient is albumin will suggest that patient is nutritionally well. So performance status is also good, and she's not having anemia also, and nutritionally also she is well. So we can, if we want, if it is early malignancy, we can go for upfront surgery also.
Okay. Is there any other investigation which is slightly better than albumin? Something similar to that? Sandeep, would you like to answer? You can try pre-albumin also if it is available. It's not available in many places. That is another alternative. So CEA, is there any role for CEA? What is the relevance of doing CEA?
It is used for follow-up, sir. If you want.
But anyway, this patient, it is not elevated, so it may not be of much relevance. And like you said, the CT scan, I'll play the CT scan.
Caleb, I need one more question. Dr. Varun, would you like to do some more investigations? Any receptors, any HER2 receptor or microsatellite instability?
Sir, based on my CT scan findings, sir, if it is a metastatic disease, I will not do any. I do not do HER2 or PDL1. But if it is a localized disease, I can go for MSI testing or MMR on IHC, sir.
So, would you recommend for all cases?
Yes, sir. Probably for all cases.
Bajaj,
NCCN recommends getting a PDL1 testing, HER2 testing, and MSI testing for all cases.
All meaning metastatic also.
HER2 for all cases?
Preferentially for metastatic disease.
Anyway, I'll come back to that when I present later. Kala, please go ahead.
Yeah.
So in a CT scan, what's the first thing you look, Dr. Varun?
Yes, sir. I will look for any free fluid in the abdomen, whether it is there or not.
Excellent. What is the next thing you look?
Sir, then any other nodules in the peritoneum. Then after doing the magnetic workup, I will go for the primary lesion. And
look at liver, peritoneum, parietic region. Because if you find something there, you need not spend time for stomach. You can decide treatment. Okay, please go ahead.
Okay.
Are you seeing?
Could you see the lesion here? I know the imaging may not be very clear. So I think you can notice the thickening in the antropyloric region. So when there is a thickening there, what will you look? What are you concerned about in a distal gastric cancer with regard to resectability? Yeah, Sandeep, please.
I'll see the planes with the pancreas, sir.
Yeah.
And I'll see whether there are lymph nodes, and if there are lymph nodes, and I'll see whether they are bulky or not, to send whether for pre-op chemotherapy. And I'll see whether the lumen is completely obstructed, completely narrowed, whether the patient has features of gastric outlet obstruction or not.
Okay. So,
But would you like to give some instruction to the radiologist so that you get the real scenario, real picture? What is your instruction to the radiologist when you ask for a CT scan? Or what is the protocol? Because sometimes a contracted stomach will look like a growth and vice versa.
Sir, I would ask the radiologist to do both IV and oral contrast so that I can visualize even the smaller lesions.
Especially oral contrast. You have to distend the stomach to see the growth. And how do you distend the stomach? Varun? How do you distend the stomach?
Sir, we can give
contrast or something else. Pardon?
Sir, we can give oral contrast, sir.
No, oral contrast is not used for, it's for used mainly for OG junction. For distal stomach growth, what do you use?
We can give water, sir.
So it's water or saline distended. And one more question. Suppose you, to differentiate the pancreatic fixity, so what is the radiograph technique? You have a posterior growth, so you want to prove pancreatic fixity. So what do you do, Dr. Vajja?
I'll ask my.
How do you?
Sorry, sir. Can you pardon? Sorry, didn't hear that.
No, posterior growth. It seems to be abetting pancreas. So how you know that it is actual fixity and not a fallacy?
I'll look for. Is there any loss of fat planes with the pancreas?
What is the answer? I could not hear.
I want to see whether the fat planes with the pancreas are maintained or not.
Now, how do you see that? It's a technique. Do you know that?
In prone position.
Make the patient prone. Kalapa, please go ahead.
So this patient was discussed in the multidisciplinary team meeting, and this was the CT report which the radiologist agreed to. It was a T3 N0M0 because there were only few subcentimeter perigastric lymph nodes. So the next question is, would you do a surgery upfront or would you want to do a perioperative chemotherapy? Sandeep?
I want to go ahead with upfront surgery, sir, in this case.
Okay. Why do you want to go for upfront surgery?
Since it is a T3 lesion without any lymph nodes, and it looks like a operable distal gastric cancer, so I want to proceed with the surgeries.
Dr. Varun, do you agree with that, or do you have a differing view?
Sir, I would like to go for a perioperative chemotherapy.
Perioperative. And why do you, why don't you tell your points? Because Sandeep wants to go ahead with surgery. So since you are choosing an opposite decision, can you explain why? What are the pros according to you?
Sir, as it is more than equal to T2 lesion, sir, perioperative chemo will be having a benefit. We'll be downstaging the tumor. We'll also check the micrometastasis, and we'll see whether the response is good or not to the chemotherapy preoperatively itself.
No, but why do you really need to downsize? Like Sandeep has rightly said that it's already resectable. So we might as well go in and resect completely. So what is exactly the reason?
There is a survival advantage as well.
Survival advantage. Okay. So can you quote any study to say that there is a survival advantage?
Sir, in MAGIC trial, sir, and even in FLOT, sir, we have seen survival advantage against the surgery arm, sir.
Okay. But what was the problem with the MAGIC? Can you talk about a little bit about MAGIC trial?
Sir, the problem in MAGIC, sir, they had not done a complete D2 resection in all the patients. Like around 42 or 43% patient, the D2 lymph node dissection was not done, sir.
Okay. Okay. And one more thing in MAGIC, complete. Yes, sir. You're going to cover in your study talk, sir. Okay.
Yeah. You ask. Then I have one.
Okay. Okay, fine. So.
Yeah. Coming. Varun. Suppose this report is T2N0M0. What could be your protocol? Now you want to give neoadjuvant chemotherapy. Suppose it is T2N0M0. What is the protocol?
Sir, in FLOT we had seen, sir, even in T2N0, sir, there was a survival advantage.
I'm not asking about FLOT. What I'm asking is, will you change? If it is T2N0M0, would you like to do something else than giving a neoadjuvant chemotherapy?
No, sir, I will go with the perioperative chemotherapy.
No, actually, I like to advise you here. See, basically, we had a CT scan, and based on CT scan, the T3 is diagnosed. So diagnosing T3 is not difficult because you see some reactions standing around. T3, T4 can easily be diagnosed, but T2 is very difficult to diagnose with the CT alone. So here I like to order for, if affordable, I like to order for an endoscopic ultrasound. So it is very difficult to differentiate T1, T2 from T3 without endoscopic ultrasound. So that's one thing for sure. And most probably you will pick up nodes. So even nodes will become and the T3, T2 status can be detected. So it will help you to go ahead with for the treatment. And coming to the upfront surgery for T3 N0, that is not recommended by guidelines. And the question Caleb asked you, is there a survival advantage? So it is there, but none of these trials compared the perioperative chemotherapy with the post-operative chemotherapy, adjuvant chemotherapy. So why do you know any trials which compared or comparing the perioperative with the adjuvant treatment? Vajja, you do know that any trials? So there are two trials, and that shows some advantage, not great advantage, some advantage for neoadjuvant treatment. Dr. Pradeep, you asked something?
Yes. So you said surgery or chemotherapy. Would you like to do something before surgery or chemotherapy for this patient? Or straight away you will take for either surgery or chemotherapy?
I want to nutritionally improve the patient, sir. But
any procedure I'm asking?
Already the albumin is 4.3, Sandeep. So
yes, albumin is 4.3, hemoglobin is 12. So patient is well prepared and there's no obstruction. Basically,
sir, I'll just come to that, sir. I'll just come to that.
Right. Fair
so we decided on doing an upfront surgery because this patient was part of a trial. This is a trial which is done, a multi-centric trial done in several centers in India. It's a neoadjuvant versus adjuvant adjuvant in gastric cancer trial. So this patient was part of this trial. So patients receive either FLOT, 6 cycles followed by surgery, or surgery followed by adjuvant. So then this patient underwent a staging laparoscopy. So this is what Dr. Pradeep was expecting. Is there any other test you are asking? So it's a staging laparoscopy. So on staging laparoscopy, no, there were no peritoneal or liver metastases. So if you don't do a staging laparoscopy, how many approximately, what percentage of cases will you be under staging?
Around 30% of the cases will be under stage.
Okay. Is there any protocol for doing a staging laparoscopy? How exactly would you do? Sandeep, yeah.
We'll get a peritoneal cytology, sir.
How many? First, you will tell me how many ports you will insert and where all will you look for.
We usually in our center we introduce a single port, sir, camera port for looking for the liver mets, peritoneal mets. Are there any deposits elsewhere?
Okay.
And then we'll introduce one more port for taking peritoneal fluid cytology.
Okay. So what will be the impact of the results of the peritoneal cytology?
If peritoneal cytology is positive, sir, it indicates a metastatic disease. But it's since it is a resectable disease, we'll do surgery, and then we'll give an adjuvant chemo. If we are planning for upfront surgery,
But this cannot be accepted because according to guidelines, suppose the peritoneal cytology is positive, what's the stage?
It's metastatic disease, stage 4.
Saying that you will do upfront surgery for a metastatic disease, that we won't tolerate. You are going ahead with surgery for T3, okay, but for metastatic disease, you are saying you are going with upfront surgery. There is no evidence to say that it is going to improve the survival of the patient.
But generally, you get your results. You don't get it immediately because it has to be centrifuged. So,
yes.
so that is why it is for it helps you in the staging, but it may not currently have much implication on the treatment of the patient.
Caleb, I beg to differ. There is we do diagnostic laparoscopy and then we as an elective procedure. And if it is neoadjuvant, we put the chemo port then and send the patient for neoadjuvant treatment. And the moment, and we could detect 20% patient having peritoneal metastasis. So we could avoid surgery in those 20%. And the cytology alone positive, the guidelines are simple, and it says it is not for cure. But again, if you want to re-challenge with the chemotherapy and systemic treatment and redo the diagnostic laparoscopy, and the cells has gone, you may consider. There is no role for upfront surgery here. I think Dr. Pradeep will agree.
Yes, sir. Yes, I agree.
Please go ahead.
So this patient was randomized to the NACT arm. So this patient received a lot. So 6 cycles of chemotherapy this patient received. So this was the reassessment CT scan. So I'll just be quick with this because there was not much of a change. The patient had a stable disease based on the RECIST criteria. So can you talk about the RECIST criteria? What is it, Varun?
Sir, it is a response assessment criteria for solid tumors based on CT scan or clinical examinations.
Okay, so this patient has stable disease. What will you call as a progressive disease?
Sir, if it is if the cumulative size is increasing more than 20%, then it will be labeled as a progressive disease.
Okay. And what is the problem with RECIST? RECIST, is it ideal for all viscous, hollow viscous? This
Yes, sir,
yeah. Pardon?
I was not able to hear the last question.
Okay. RECIST, is it acceptable by everyone for hollow viscous, like intestinal or gastric tumors? The problem with this, it's ideally designed for solid tumors, so it may not really work that well in a hollow viscous. That is the only drawback. So again, as per the trial, second reassessment was done after 6 cycles, and patient was taken up for surgery. So what will be the extent of resection if you're going to take this patient up for surgery? Sandeep?
Cell gastrectomy with D2 lymph node dissection would be the ideal choice.
Okay, since the patient has already received neoadjuvant chemotherapy, is there a case for doing only D1 gastrectomy like was done in the MAGIC trial?
No, so we'll do a D2 lymph node dissection only.
Okay, correct. And what will be the extent of lymphadenectomy? What all groups will you remove? Since this is a distal growth, what all stations will you remove?
1, 3, 5, 4 SB, 4D, and 7, 8, 12.
Okay. Anything else, Varun? You want to add something?
Sir, 8A, 9, 11P, and 12A.
Okay. So why not 10?
Sir, there is no role of removing a station 12 lymph node for a distal gastric cancer. Only in proximal gastric cancers, we should address station 12 nodes. Station 10.
10. Okay. And why? What is the other problem with 10?
Sir, it is close to the spleen, sir. So it is very difficult to assess surgically.
Okay. Morbidity is also high. Okay, what will be your reconstruction plan?
Sir, my reconstruction plan would be Roux-en-Y reconstruction or gastrojejunostomy and feeding jejunostomy.
Okay, Sandeep, any other alternatives you have in mind, or would you agree with Varun?
We'll prefer a Roux-en-Y gastrojejunostomy or a Billrod 2 procedure, sir. Since the chances of
and why would it be so?
Chances of alkaline reflux gastritis are less with Roux-en-Y when compared to Billrod 2.
Okay. And what all will you counsel the patient with regard to the surgery and the post-op morbidity? Sandeep?
I'll explain him that patient might have chances of anastomotic leak there are chances of bleeding. I'll explain him about bleeding, and post-operatively, I'll explain him about physiotherapy and spirometry exercise that he need to do.
Do you talk about dumping and what is dumping?
I'll explaining about dumping syndrome, sir.
Yeah, can you explain dumping briefly?
Since the duodenal passage is diverted, food directly hyperosmolar food directly enters into jejunum. So initially, after taking food, patient will have third space loss. Suddenly, he will have syncopal attacks, and after few hours of
there are two kinds of dumping syndrome. One is early dumping and what is late dumping.
Okay.
And what's
This early dumping is immediately after taking food, sir. After 2 to 3 hours of intake of food, patient, because of if he has high glucose content food, there will be sudden hyperinsulinemia.
early dumping occurs within half an hour. Late dumping occurs in after 3 hours.
Yes.
And what is the difference in etiology?
Early dumping is because of hyperosmolar third space loss, sir. And late dumping is because of sugars and hyperinsulinemia.
Is there a difference in symptoms?
Early dumping, patient will have syncopal attacks. Late dumping, patient will have sweating.
Okay. Which one is caused by hypoglycemia?
Late dumping is caused by hypoglycemia.
I'll come back to Varun. Regarding the margins, how do you decide on margins for after gastrectomy?
Sir, for the proximal margin, I would like to take a 5 centimeter margin. And the distal margin for a distal gastrectomy will be, I will be resecting at the D1.
So I think, Varun, here we have to consider some other things, like
Yes,
how
sir.
the differentiation, the type, the Borman type. So those things are important. Do you know there are basically two kinds of gastric cancer? What are they?
Sir, based on the pathological type, Lawrence classification, there is intestinal type and diffuse varieties.
Which one needs longer margin?
So the diffuse variety will need a longer margin, sir. It is an infiltrative type.
Okay.
So we'll be needing one.
So other than this Lawrence classification, do you know some other classification which help you deciding the margins?
Or a microscopic classification, for microscopic, there is a Borman's classification.
Okay.
Borman's classification in this type 1 is polypoidal, type 2 is superficial ulcero-proliferative, type 3 is ulcero-infiltrative, and type 4 is diffuse.
So
and
what's
type 5
the margin for type 2? What is the margin for type 4?
For type 1 and 2, I can take a 3 centimeter margin. For an infiltrative, I will take a 5 centimeter margin.
Okay. So can you tell me what are the standard gastrectomies? Standard radical gastrectomies. What are they?
So standard gastrectomy is in which we do a complete D2 resection, sir.
Okay.
We remove station 1 to 12 nodes. That is total gastrectomy and distal gastrectomy. Okay. Then there are modified gastrectomies, sir. In that we do less than D2 lymph node resections.
So can you tell me the surgery radical gastrectomy in which you don't remove station 2?
Sir, in D2 radical distal gastrectomy, we will not remove station 2 nodes.
Great. And so when will you remove station 13 nodes?
Sir, for station 13 nodes, sir, if my patient is having a infiltrative growth which is invading the first part of the duodenum, then I would like to address station 13 nodes.
And what will you do? Suppose the lesion is infiltrating the greater curvature.
For the greater curvature, sir, I would like to address station 12 nodes, 10 nodes, sorry. Sir. the splenic hilar nodes.
Do you need to do splenectomy for that?
Sir, I will try to preserve the spleen.
And what
It
if
is-
you say station 6 is involved? Would you like to do some more station?
Sir, if station 6 is involved, I would like to address middle colic nodes, sir, 14V nodes.
Okay, cool, great. Thank you. Caleb, please go ahead.
Yeah. So what will you be talking about unresectability to the patient, unresectability and inoperability, Varun? Is there a chance of this patient becoming unresectable or inoperable during surgery? And how will you explain to the patient?
Sir, if direct invasion into the pancreatic head is there, sir, then it can be an unresectable tumor, because for doing a Whipple's for a gastric is not advisable.
Okay. Anything else at the duodenal end?
Yes, sir. If the distal margin I am not getting, sir, if I am not able to transect at D1, then
So how would you decide that you've gone maximum distal enough?
sir, intra by palpating the tumor I can decide, sir. Or if I'm not sure, then I can use the help of an endoscopist.
Okay. No, I'm talking about in terms of the distal margin. How distally can you go? How will you know where the ampulla is? Because from outside, how will you decide?
The pyloric thickening will be palpable, sir.
Okay.
Beyond that, sir, I will be able to palpate the duodenum, first part.
Okay. Then ideally, you will look at the gastroduodenal artery behind the pylorus, and usually we don't go distal to it because there'll be risk of injury to the ampulla. Okay. And I'll just play a video. This is the before the CT surgery. You'll have to plan the surgery, right? So would you
Yes.
also look into what all will you look into the CT scan? So I'll just play the CT scan. What else will you look at? Is there any other surprises you will anticipate during the surgery, which you can avoid by reading the CT scan preoperatively? Any abnormality in the vessels that you will look at?
Sir, any aberrant vessels coming from left gastric, sir?
Okay. What is the aberrant vessel which can come from the left gastric?
Left hepatic, there can be a aberrant left hepatic or accessory left hepatic vessel, which can be a direct branch of the left gastric.
Okay. So how would you safeguard it? Of course, one is to see the CT scan preoperatively. Intraoperatively, how will you safeguard it?
Sir, first I will, if I am sure with the CT scan, like I have found it in the CT scan, then I will try to find the vessel by dissecting the hilum first.
No. Then you can after dissecting the left gastric, you can maybe apply a clamp on it to check the liver also. That is one way you can do, or dissect the left gastric distally also a little bit further. Okay, so for this patient, we did a distal subtotal lead to gastrectomy, and intraoperatively.
Can I ask a question? I'll ask Panja. Suppose if you have a only replaced left hepatic artery,
Yes.
coming from the gastric artery, so how do you preserve it? When will you preserve it? And suppose there are multiple nodes also you see during the surgery, and the resection becomes almost necessary. So would you ligate artery?
No, sir.
Caleb told that you can clamp and check, no?
If there is an accessory right hepatic artery which is arising from gastroduodenal artery or SMA, then in that cases, patient will have blood supply to the right side, right liver. Then in that cases, we can ligate the replaced right hepatic artery which is arising from the left gastric.
I think the answer is, yeah, Kalap, would you like to say something?
No, Sandeep, we were talking about a replaced left hepatic. So left hepatic will come from the left gastric, left hepatic arising from the left gastric. So that is where if you apply a vascular clamp and check on the left gastric, if it is an replaced left hepatic, accessory left replaced left hepatic, then there'll be darkening of the liver. So that way you can and you can dissect the left gastric further and go up to the branching of the replaced left hepatic, and then you can ligate the left gastric. But sir's question is very specific. What if there are nodes proximal to it at the origin of the left gastric? So what will you do, sir is asking.
And nodes are there, and nodes are stuck nodes. So you have two options: either to have a compromised dissection and keep some tissue there, or ligate the artery. So which one will you do?
I'll compromise.
I'll come to the answer. So first of all, you look at other factors, whether it is only a replaced artery and there is some normal arteries also supplying, and what's the size of the artery. And lastly, you try to clamp it and see for liver change, because liver usually have multiple blood supply. The portal venous supply is maybe sufficient. And all of these tests are okay. Liver is not changing color. You can sacrifice it. But given said that, we had one instance of liver necrosis. Among many patients dissected, many have been formed, but one patient had left of necrosis, which was managed later. So this is the answer. Please go ahead.
Yeah, so the findings, there were no growth palpable and no liver or peritoneal disease. And the reconstruction we did was a Roux-en-Y gastrojejunostomy. So these are the introp pictures. And the final histopathology. So going by it, before the final histopathology, after doing the surgery, would you do the grossing yourself, or would you send it to the pathologist for grossing? Which has more advantages over the other? Yes, Sandeep.
If we do by ourselves, sir, we can check the distal margins, sir. We can check the margin status, proximal and distal margins also.
I'm talking more in terms of the lymph node harvesting for the grossing. So would there be more nodes if we dissect or if the pathologist dissects?
If the pathologist dissects, then the chance of getting more nodes.
Okay, Varun, would you like to answer that?
Sir, we like to do the grossing ourselves, sir. So we can group the nodes based on the location, sir. And the harvest will be better if we do it ourselves.
Yeah, correct, Varun. The harvest will be better if we do. And one more thing is, after the fixation of the specimen, it will be difficult for the pathologist to orient and look for each and every station. So ideally, we should remove the nodes and send it separately after labeling it, because all the stations 1, 3, 5, every station, it will be difficult for the pathologist to harvest themselves. So this patient, there were no viable tumor cells seen because there was a complete response. And none of the 47 nodes were involved by the tumor. So how many nodes need to be dissected, Sandeep?
16 nodes.
Okay. And so the staging was YPT0, N0, M0.
Dr. Saleb?
Yes, sir. Please, sir.
15 nodes. So I believe it should be 16, but ideally 30. What is your view?
No, it is for the sake of staging, minimum 16.
Minimum 16s are required, but it's recommended to take out 30 nodes, isn't it?
Yeah. So this patient had received all the cycles of chemotherapy preoperatively, so it is okay. But this is part of a trial. But had this patient received 3 cycles of chemotherapy, would you stop with it? Since the patient has received complete response, would you stop at 3 cycles chemotherapy, or would you like to give the adjuvant 3 cycles also?
We'll continue with rest of the cycles of adjuvant also, sir.
Okay.
The PCR doesn't equate to overall survival, so we'll give the rest of the cycles also, sir.
Okay. So, say if this patient had received ECF and the patient had a poor response, there was no response to the chemotherapy, would you change the chemo and give the patient FLOT? Varun?
No, sir, I would like to continue with the ECF regime.
But that ECF has not had any effect. Would you still continue with ECF?
Yes, sir.
Okay. Okay, correct. And so post-operatively, what will be the post-op care that you give? When will you mobilize the patient? When will you start the oral feeding and all?
Orals.
Sir,
Yes, Sandeep.
Orals can be allowed from day 0. Oral liquids can be allowed from day 0 or the day 1, sir, post-operative day. And Ryle's tube can be removed on day 0 or day 1. Patient can be mobilized on the day of surgery or day 1, sir. And solids can be allowed on from day 3, and patient drains can be removed on from day 3, and
Okay.
Foley's can be removed on day 1, sir.
Okay.
And
thank you. Sir, any other points you want to add, or we'll move to the next case?
I think I know we have only 5 minutes left. Rather
Yes,
than
sir.
moving to, next, I think we can ask some more questions here. Won't be
Okay,
able to finish anything in here.
Okay. The second,
Yeah. So I'll finish up whatever supposed to be covered. I will ask some questions.
yes.
Coming back to Vajja, you wanted upfront surgery, but we thought it is nice to give a neoadjuvant. So which are the scenarios in which will you do upfront surgery for a stomach cancer patient?
patient has distal.
Tarmon,
Yes, sir.
Caleb and Pradeep, I think we should do the other 2 cases also. You can take 15 minutes, 15, 20 minutes, and then
Whatever is
Okay.
case I'm asking questions.
do it because it's important for them to learn. But do it rapidly.
I think Caleb, you rush through the case immediately, then we'll ask questions.
Yes, sir. Okay. Okay. I'll do that. So the second case is a 47-year-old gentleman. He had vomiting for 2 months, and history of generalized weakness, loss of weight and appetite, and epigastric pain. And this is on clinical examination. He had no pallor, no supraclavicular nodes, but he had his performance status was 2, and he looked dehydrated and poorly nourished with the distension of the abdomen, upper abdomen, and there was a VGP. And this is the, I'll just, okay, I'm sorry, I'll just play this CT. Okay. So what exactly is being done?
We are evaluating for succussion splasher.
Okay.
Indicates there is gastric outlet obstruction in this patient. If we can auscultate, then it indicates patient has gastric outlet obstructions.
Okay. Okay, what is being done now?
This is ausculto percussion, sir, to know the distal extent of the greater curvature of the stomach.
Okay, and do you think these tests are really relevant in this era of CT scans for all patients? Sandeep?
For management, sir, for planning for surgery, this is required, sir.
Okay, so this was the upper GI endoscopy report of the patient. So he had a there was food residue was there, because this is despite two days of Ryle's tube washed with saline. He had a giant ulcer in the pre-pyloric region, causing minimal obstruction. But the endoscopist could somehow enter into the mucosa, into the duodenum, and he could see. So, and his biopsy was adenocarcinoma, and hemoglobin was 10.1, albumin was 2.2. And this was the CT images. You can see that there is a thickening in the antropyloric region. And this is the stomach, distended stomach, which you can see. So CT scan showed no metastasis, diffuse wall thickening of pyloric canal with narrowing of the lumen, and minimal, only one small node was there, and minimal ascites. So what are the treatment options for this patient? One is, would you go for a nasojejunal tube placement or a stenting? Varun?
I would go for a nasojejunal tube for feeding, sir.
Okay. But how will that help, Varun? Of course, feeding can be done. What about the outlet obstruction? This patient is presented with vomiting. How will placing a nasojejunal tube alone help? Yeah. Sandeep, would you have a differing view? Okay. Otherwise, the other alternative is exploratory laparotomy and proceed. What will you choose, Sandeep, between the two? Choose something, Sandeep.
Exploratory laparotomy and procedure.
Okay. Varun, would you change to exploratory laparotomy or would you stick to nasovaginal tube placement?
Sir, I will like to put a nasovaginal tube.
Okay.
And I will not do a exploratory laparotomy upfront. I will like to do a staging laparoscopy first.
Okay. How will you treat his vomiting?
Yes, sir.
Because vomiting will be persistent. Even if you put a nasovaginal tube, there will be vomiting will be there. Would you keep a nasogastric tube also inserted to?
Initially, for decompression, I will keep a nasogastric tube.
Okay. Fine. Okay. So then the other alternate, since Sandeep chose surgery, if we go ahead with surgery, what will be the surgery that you do? Would you do a D2 gastrectomy or would you do a D1?
Can I ask a question?
Yes,
Dr.
sir.
Bayo? Here, I think the scenario is it's an obstructed gastric cancer. Whether you want to go up with the surgery, curative surgery is the first question we like to ask. And then again, another question is whether you would like to give some kind of neoadjuvant treatment. So either you have to do some curative surgery or you have to palliate it if it is not beyond that. And if you want to put a nasovaginal tube, so what is the purpose of putting nasovaginal tube placement or stenting? What do you do? Where do you want to do that?
Sir, as this patient is not nutritionally well, sir, albumin is 2.2. Okay. I would like to improve the nutrition first before proceeding to surgery.
Excellent, well accepted. Because or would you like to give neoadjuvant treatment with an nasovaginal tube and then operate?
Yes, sir. That will be my preferred option.
Okay. And
if probably the tumor might downstage and the obstruction might relieve in response to chemotherapy. Yeah.
No, there is a strong issue with that. If you do that, so the patient is a sick patient, and you are going to support the patient, bring him up, and is this patient is going to tolerate the entire chemotherapy and surgery? No. So here, I think the advantage of putting up a tube and managing is to make the patient build up for a surgery. Otherwise, how can you have the entire float protocol or magic protocol with the nasovaginal tube placement? It's very difficult. So after that, patient may not tolerate surgery. The completion rate may be less. So that's why most of the guidelines very categorically says that if it is obstructed bleeding, you go ahead with the surgery. And another thing I like to bring here is the trials which looked into the advantage of giving neoadjuvant therapy have never compared with the adjuvant therapy. So all the survival advantage you are getting in these trials is not because chemotherapy is given upfront, because surgery only done for other arm. That is the main thing. So here in obstructed case, I think it is perfectly acceptable if the patient is fit to go ahead with the definitive surgery so that the obstruction is relieved, patient is happy, and patient can tolerate definitive chemotherapy as an adjuvant. And adjuvant results are not bad. The only thing you should take care when you do a surgery for an emergency is to do a proper D2 gastrectomy, distal gastrectomy. Don't compromise on the surgery because the patient is obstructed. That is an important message. Please go ahead.
Yeah. So, but one question I wanted to ask you, Sandeep. So on the CT, on the endoscopy, the endoscopist was able to enter into the duodenum. So in this case, wouldn't Varun's option also be acceptable because he feels that there is not a very great obstruction. It's a possible obstruction. So would you consider his option or no? Or would you go for exploratory laparotomy? How would you decide?
As Sir said, patient is in partial obstruction. So patient may not tolerate FLOT4 regimen even.
Actually, the clinching point there was that the patient was dehydrated and the patient was almost, he was like emaciated. So that is very important. And for such a patient, it may not be easy to give do a nasovaginal tube placement. One more thing, in between chemotherapy, after giving the first cycle of chemotherapy, he develops severe gastric outlet obstruction. Then again, managing the patient will be difficult. So this patient, would you go for doing D2 gastrectomy or versus bypass only? So of course, like Dr. Chandramohan said, D1 gastrectomy is not an option at all. I just put it for the case of discussion. But would you do a D2 gastrectomy or would you do a bypass only? How would you decide? And in this particular patient, you saw all the parameters. How would you decide? What will you do between D2 gastrectomy and bypass, Varun?
Sir, if I am not able to pass the nasojejunal tube, I will like to do a bypass first.
Yeah, okay, yeah. So what kind of bypass will you do?
Sir, I would like to do a loop gastrojejunostomy.
Okay, very good. And why not Roux why?
Yes, sir.
Why not Roux and why? Roux and why? Why not a Roux and why gastrojejunostomy? Why
loop?
Yes, sir. But Roux and Y will be a more complex surgery, sir. Two anastomosis will be doing, sir.
Yes.
And it is not feasible for this nutritionally compromised patient.
Okay, okay, fine.
Dr. Selab, can I ask a question?
Yes, yes, sir, please, sir.
So would you do a feeding jejunostomy also whenever you're doing a bypass or you're doing a gastrectomy? In this scenario, in the current scenario?
No, sir.
No, sir.
Dr. Varun?
No, sir.
Dr. Sandeep?
No, sir.
So I'll put the question in a different way. Would you do a feeding jejunostomy instead of doing a gastrojejunostomy? So, Sandeep.
No, sir. We'll do a gastrojejunostomy.
Okay, correct. That is very important. Feeding jejunostomy will never be the treatment for a gastric outlet obstruction because the obstruction won't be relieved by the feeding jejunostomy. So what are the factors which guide decision making? Like we decided, number one important thing is the symptoms of the patient and the general condition of the patient, nutritional status of the patient. That should guide the decision making. And this is the intro. We decided to do a gastrojejunostomy for this patient. And as you can see, the serosa was involved, serosa of the stomach. So we did there was a dilated stomach serosal involvement. It was T4A. And we did a loop gastrojejunostomy. And the ascitic fluid which we sent for malignant cells were negative. And so what should be the further plan for this patient? How will we build up this patient? Would you give TPN or would you give enteral nutrition, Dr. Sandeep?
We'll start enteral nutrition as early as possible.
Okay.
We'll give albumin supports from post-op day 1, sir.
Why would albumin support be helpful in this patient?
Since his pre-op albumin is low and he's nutritionally also very weak, so till the enteral feeds he gets tolerated, so we'll start him on.
Varun, would you have any differing view on this, Varun?
Sir, until the patient is tolerating enteral diet, sir, I will give parenteral nutrition as the patient is not nutritionally well.
Okay, that can be a short bout of parenteral nutrition can be considered. But then this patient, we inserted a nasojejunal tube also. So on day 1 itself, we started nasojejunal feeding. And by day 2, we've started oral feeding. So we didn't have to give him any parenteral nutrition. And with regard to albumin, if the albumin is just a marker of the nutritional status. So if the patient's albumin is low, supplementing with albumin may not be beneficial. Unless you are giving it for persistent hypotension, you want the patient's BP to come out for maintaining the oncotic pressure. So that is something which we need to keep in mind. So further, would you do surgery versus neoadjuvant chemotherapy for this patient? So I think for this patient, you'll again have to decide. Basically, this patient has to build up nutrition and he can go for neoadjuvant chemotherapy, considering that it's T4A. So we'll quickly go to the last case. It's a 68-year-old male with a history of difficulty in swallowing food. and he had history of alcohol intake for 20 years. ECOG was 1, and there was no significant findings as such. His endoscopy revealed a circumferential ulcer proliferative growth from the G junction to the body, and the antrum, pylorus, and duodenum were normal. The biopsy was a polydifferential adenocarcinoma, and this is the CT scan finding. Okay, I'll skip the CT finding because of want of time. There was just thickening up around the proximal part of the stomach. So this is the circumferential wall thickening in the G junction and proximal stomach with few enhancing lymph nodes along the left gastric artery. What would you do for this patient, Sandeep?
I would like to give an I would like to do a diagnostic lab, sir, first.
Correct.
Then I'll see is there any peritoneal mets, liver mets, and I'll send a peritoneal fluid for cytology. And then I'll plan for if
all are negative.
And then I'll plan for a new perioperative chemotherapy.
Okay, Varun, would you agree with him?
Yes, sir.
Okay, fine. So this patient received perioperative chemotherapy, which was capecitabine and oxaliplatin, and reassessment was done, stable disease as per RECIST criteria, and the endoscopy also didn't show any changes. So surgery was planned after 4 cycles of chemotherapy. So what will be the surgery that you will do for this patient?
Sir, I would like to do a D2 radical total gastrectomy with a proximal negative margin, sir.
But it was the circumferential opening inside. You find that the disease is confined to the proximal part of the stomach. Would you do a proximal gastrectomy?
No, sir. The nodal burden is high, sir.
Okay.
Then if you are planning for a proximal gastrectomy, you will not be able to do a complete D2 resection. So for this patient particularly, I will go for a D2 radical total gastrectomy with a Roux-en-Y reconstruction.
If the CT doesn't show any nodal involvement, would you consider proximal gastrectomy?
Sir, the previous pre-chemo CT was showing, sir, N2 disease.
Okay.
Okay. I would like to address.
Okay, good. So
I have a number one issue. So what is your diagnosis in this case? Is it stomach cancer? It is OG junction cancer?
So the I would like to ask Sandeep.
It is a stomach cancer, sir. It could be Stewart type 3 cancer.
The Stewart type 3 is OG junction, not stomach. So how do you classify a OG junction cancer versus a stomach cancer with the given picture?
Since the tumor is extending in totally into the till the cardia and body is also involved, so I consider it to be a stomach cancer.
No, you cannot do that because there is a classification by Stewart, which has some criteria, which is the first landmark is 1 centimeter above the OG junction, second landmark is 5 centimeter above the OG junction, another landmark is 2 centimeter down to OG junction, and another landmark is 5 centimeter down to OG junction. There is a landmark, and there is a concept of epicenter. So you have to be very clear in what is the case. Is it OG junction type 3 or it is stomach cancer? How do you differentiate in the given picture?
If the epicenter of the tumor lies in the OG junction and it is within 5 centimeters of the OG junction and towards stomach, I'll consider it to be a Stewart type 3 cancer, sir.
Excellent. Yeah. I have another issue. So Dr. Varun wanted to do a total gastrectomy. But we also discussed that the margin, or how much margin is needed proximally, distally, and the proximal margin, especially in such a lesion with a big growth and diffuse character, is going to be 5 centimeter. So how are you going to do a total gastrectomy, get 5 centimeter proximal margin and reconstruct? So by the description, this look like Borman type 3 or 4, which necessitate a 5 centimeter proximal margin. And you want a total gastrectomy, entire stomach to be removed. And then how are you going to reconstruct it? So that is the importance of diagnosing it as an OG junction. So there are two ways of doing it. So either you have to do a colonic reconstruction that is going to be messy, or you like to consider it as a stage 3 severe type and try to save some stomach for reconstruction. That will be better, easier. And one more concept, you can compromise a bit on the actual margin on the esophagus, but it has to be at least 3 centimeters practically. And where you can bring in a jejunum. Please, Kalap, go ahead.
Yes, this patient, his main epicenter was in the body of the stomach along the lesser curvature, and intraoperatively the entire stomach was involved along the lesser curvatures, and it was stopping short of the pylorus, and there was an enlarged splenic node. Total D2 gastrectomy was done with a splenectomy because while dissecting the splenic hilar node, there was an injury to the splenic vein, and followed by esophageal anastomosis. So this is the final histopathology report. The tumor site was in the body along the lesser curvature, and it was a polydifferential adenocarcinoma. Size was 9.5 into 6 centimeter. And this patient didn't have any treatment effect to the chemotherapy. And margins, proximal, distal, and radial margins were free. Proximal margin was 3 centimeter, and the distal margin was 3.5 centimeter. And 12 out of 16 nodes were involved by tumor. And the splenic node, which was removed, there was a extranodal extension also. So it was a T4A and 3AM0 chemo. So exactly in this patient only, if chemo, what chemo are we going to give? It has to be the same chemo which we already discussed. And anything else, sir? Because there is already 8:20. I think we should move on to your talk.
Thank you.
Thank you. Thank you, Sandeep, and thank you, Varun, and thank you, Dr. Pradeep. We'll move on to the talk by Dr. Chandramohan.
Dr. Varun and Dr. Sandeep, thank you.
Srijan has.
Thank you, examiners, and thank you, examinees. We request Dr. Caleb and Dr. Pradeep Jaswal to kindly wait for the Q&A session, which follows the expert talk. We request Dr. Chandramohan to kindly share his screen and deliver the expert talk for today's masterclass.
Am I visible and audible?
Yes, sir. You are visible, audible, and the screen is also
visible, sir.
Yeah. Okay, thank you. So thank you very much for calling me for this meeting. And it was actually an honor for me. And I congratulate Srijan and Subramanian Rao sir for doing this thankless job for 3 or 4 years. It's so amazing. And it's a treasure of knowledge in YouTube. So even for preparing this meeting, I went and referred the previous meeting where Ramakrishnan was done a perfect job. So it's a important asset for us, our association. So coming to my topic, stomach cancer. Is my slide moving?
Yes, sir.
Yeah. So stomach cancer is an important topic as far as we are concerned because of the reason it's a very aggressive disease. So we recently looked into our survival, our 5-year survival of stomach cancer, and we could find out that it is nearly 40%. And that is one of the good achievements. Usually the 5-year survival is of stomach in National Cancer Registry after good treatment will be something like 20%. And one thing which is good happening is the number of stomach cancers are going down in most places in India, most cancer registries in India, except some places. And so in certain places, number is increasing. One being the North Kerala Cancer Registry, which is showing the increasing trend of stomach cancer, and stomach cancer is number 2 cancer in that area, and Dr. Satishan is really worried about that. So coming to my presentation, I'll be rushing through whatever lacunae we found out during the presentation and this discussion regarding staging workup and new adjuvant recommendations and adjuvant systemic treatment, adjuvant RT, and surgical principles and recommendations and future directions. Yeah, one thing which we should understand, the NCCN guidelines, which we all consider as a holy Bible of oncology, is a bit confusing because it gives a lot of investigation which we don't use for day-to-day practice. And usually a patient needs a biopsy, a triple contrast CT scan, and then comes a PET scan So whether PET scan is needed, I will explore here. And then it asks for an endoscopic ultrasound. So the indication for endoscopic ultrasound I mentioned during the class. And then comes, as Dr. Vajja has pointed out, they're asking for universal testing for microsatellite instability, which is not widely practiced in our country. But there is a new thing. I think maybe in future it will come very strong because the immunotherapy is going to come in a big way. So why do you need a pet when do you already have a cat? That's a question I like to ask. My answer to that question is actually you don't need it because in a primary setting, because our CECT scans are so evolved and certain type of cancer, diffuse type cancer, signatory cancer, its PET is not much useful. And CT is more widely available and CT is not very expensive in most centers, except some centers like Indo-American where they have package. And PET scan is maybe used only for unequivocal cases. And the issue with the PET scan is one of the commonest site of the metastatic presentation is peritoneal nodules. And PET fails miserably in diagnosing peritoneal nodules. And this is a PET scan. A patient landed to my OP 2 days back with a PET scan done with an ascites. And the patient came from Tamil Nadu. And there was a PET scan with the patient. There is high resolution CT scan with the patient. The PET showed a peritoneal disease. At the same time, when we looked into CT scan itself, our radiologists could diagnose all these things, peritoneal nodules, ascites, by looking at the stranding. So it is an expert radiologist, he can have all the information which is available from PET by just reading a good CT scan properly. And there is one more issue which I like to tell in a health economic point of view. There are more than 60,000 new cancers of stomach is diagnosing in India annually, and India has approximately more than 5,500 CT scans, but there are only 450 PET scans. So how are you going to do a PET scan for all patients across the nation? And the source is ChatGPT, which I don't think is correct. So coming to the next question, how many biopsies need to be taken? And our candidate answered correctly. It is 7. And biopsy has to be done from an edge of the lesion. And actually there is an evidence, and please quote this evidence if some examiner asks you. And coming to the peritoneal nodules, the peritoneal nodules are so tiny and it's very difficult to know it even by inspection. So recently, 3 weeks back, I operated on a patient and a diagnostic laparoscopy was showing nodules. And okay, we thought we will operate the patient. We opened up, then there is no nodules later on. So what happened was then we took a biopsy. So biopsy turned out to be positive. So it may not be visible to your naked eye. Actually, these are so tiny nodules, and only high-end laparoscopy, especially 3D, 4K, can diagnose it. So it has a role. And ideally, we have to do a diagnostic laparoscopy for a case which is more than T1A without do. That is pretty much a recommended practice because peritoneal nodules can come. So as I pointed out, we did a study on our rectal cancer patients, operable cancer patients, and we could find out 20% are having peritoneal nodules positive, irrespective of early disease in CT scan. But I think it's mandatory to do a diagnostic laparoscopy before neoadjuvant chemotherapy for a bulky lymphadenopathy, fat standing, and ascites. So which will detect the peritoneal nodules, which will make the patient stage 4 and candidate for a palliative treatment. Again, coming to the treatment, we know that it is world over, it's different. And the Americans, still they don't believe in good surgery. They tend to do more D1 or D0 dissections. And even now, a lot of patients are subjected to post-operative chemoradiation. But the supports come from the McDonald trial as well as in CalGB trial. And coming to Europe, they have made a trend by relying on perioperative chemotherapy, where MAGIC trial by Cunningham first showed it is improving the survival from 23 to 36%. It's pretty remarkable. And the same finding was used in FN CLCC trial in France, which is slightly different chemotherapy with a different regime. And the MAGIC trial, you should all understand that the MAGIC protocol is very rarely practiced all over nation or our world because it is so cumbersome. The patient has to get continuous infusion for a long period of 5 FU. There is real headache. And now the FLOT4 regime, which is invented in Germany, has shown that it has superiority over the existing MAGIC regime. So it is accepted as a standard of care in most countries in the world. And even now, I think we are with the ISOPEC trial and New Ages trial, it is also showing superiority for even for OG junction tumors. I think FLOT is going to have more important role. And moving on to the Asian countries, we see that they still rely on surgery, upfront surgery, beautiful D2 dissection with radicality, and they still rely on mostly on adjuvant treatment supposed to be shown by the ACTGC in Japan as well as classic trial in Korea and JACRO trial in Japan, where they used S1 as the main drug in Japan, and in JACRO trial they also added docetaxel with improvement in overall survival. And coming to the basic question, when a patient comes to you with a operable patient with a GU, if there is GU, the patient has to undergo a primary surgery, because the reason I mentioned during the case discussions, very difficult to give neoadjuvant treatment even by doing a nasogeneal tube. So it is better to have the surgery first and rely on the Asian protocols to give adjuvant treatment later on. Or if there is no GU, we can consider anything more than T2 N1. We have to consider perioperative chemotherapy, which is the standard of care nowadays. So this picture depicts the journey of adjuvant as well as neoadjuvant. So in the first figure, you are seeing that 2001, the McDonald regime, which is started in US, was relying on adjuvant CRT. Then 2006, the MAGIC trial by Cunningham showed advantage of doing perioperative chemotherapy. So now in world over, perioperative chemotherapy, especially after the discovery of FLOT regime in 2019, is considered as a sacrosanct, and it has replaced most of the regimes, even for OG junction tumors, as I just pointed out. And coming to Asia, still the adjuvant S1, then adjuvant capox by a classic Korean trial is ruling, but the role of adjuvant RT, which is disproved by the trial, ARTIST trial in 2015, is a take-home lesson for us. So now we have Top Gear and Critics trial, which is running, which will be looking into the neoadjuvant CRT. I think in the near future, it will come with an answer for this question, and sometimes neoadjuvant chemoradiation may become a standard of care after these trials. And another thing which is challenging and coming out is the role of pembrolizumab, especially after the good outcome, good response, which we saw after the Keynote 585 trial. And I really think that immunotherapy is going to play a significant role in the management of even operable stomach cancers. And look at the survival of stomach cancer. So you can see that the MAGIC trial from 23, it has gone to 36% 5-year survival. Intergroup trial, by some indirect comparison, they are not directly giving trial, but some indirect comparison, we can find out that it should be approximately 43%. And the FLOT4, again, compared MAGIC trial with the FLOT regime, which is showing 45% 5-year survival. And if you look at the Japanese trial, they are showing better survival even without adjuvant. Even the control arm of Japanese trial is showing the better survival than most of the drug test arm of most of the trials. So basically, there is a rule called 10% rule. So what is 10% rule? If you think that some modality is going to bring in change in survival by 10%, it is going to have significant impact. So most of the adjuvant, so neoadjuvant trials are showing nearly 10% or more survival advantage. Let it be MAGIC trial, FLOT trial, ACT trial, capox trial, all trials are showing. So this reiterates the importance of the adjuvant or neoadjuvant protocols in carcinoma stomach in improving survival. So to make it very simple, what's the choice? For me, I had made a simple algorithm patient comes with a good performance status and without significant comorbidities, float should be followed. And the moment a patient had a lower performance status and multiple comorbidities, you should be relying on some other regime. And magic is run out of favoritism in most places. Either you would have FOLFOX regime, CAPOX regime, or oxalate S1 plus oxaliplatin. Again, coming to the adjuvant, especially after a primary surgery, the moment it is more than T2N plus, you have adequate D2 dissection and there is with limited nodal disease or non-nodal disease and negative margins, the patient has to have some kind of adjuvant chemotherapy. The moment it is having no adequate D2, patient have a lot of nodes, almost all nodes are positive with a node of perinodal infiltration and the margins are positive, then we have to consider adjuvant chemoradiation. So what are the adjuvant chemoregimes? CAPOX for 6 months, FOLFOX for 6 months, 1 year of S1 therapy, or 1 year of S1 docetaxel. So what is the adjuvant chemotherapy treatment? In a treatment-naive patient, you should first have some FOLFOX or FLOR or 5-FU for 2 cycles. Then you give continuous infusion with RT with 5-FU or capecitabine, and then you have the same regimen, which is FLOR, FOLFOX or 5-FU for 4 more cycles. This should be the adjuvant chemotherapy regime in a patient who had otherwise not undergone a neoadjuvant protocol. So these things are very important. Rehabilitation. I think we have to reiterate the importance of rehabilitation. The patient is coming to you with an operable stomach cancer. You are subjecting the patient for a neoadjuvant protocol. So it's very important to give advice to the patient, which always we do for esophagus and stomach, and sometimes rectum also, to start doing exercise. And patient may find it a little strange, but I'll tell the patient, we are going to have 2 or 3 months of neoadjuvant treatment. It is very important to have a healthy food. I'll send the patient to our dietitian for a dietary management, physiotherapist for teaching some respiratory incentive spirometry, and ask the patient to do a proper exercise. It's very, very important. It has improved our results. And curative surgery for carcinoma stomach, which I just pointed out, even without adjuvant, the survival in Japan is above 60%. With neoadjuvant protocols, the survival in most Western countries is less than 60%. So that reiterates the importance of doing a proper surgery. In the right-hand figure, you can see that you have an early disease and advanced disease, and in between you have a D2 gastrectomy zone, where the surgical expertise is playing a crucial role in deciding the fate of the patient in terms of overall survival. So what are those strategies? When you look at the evolution of surgical treatment, you can find out that it started in 96, where the D2 lymphadenectomy was done by MRC trial, which was a negative trial. That Dutch trial and then a Japanese trial, which looked into more than D2, could not find out any advantage. Then a Dutch trial. As a Dutch trial, even though it was a negative trial at the period, long-term survival, 15-year data showed that those patients who are not positive and intestinal type of tumors, it showed some advantage in the 5-year survival with the in response to the gastric cancer related death. And the late trials are showing towards some role of minimal access surgery in stomach cancer. I will allude into that later. And what are the surgical principles? One is approach, which I will discuss at the last. And coming to second important thing is margin, which we already discussed during the class. I'll reiterate again, and lymphadenectomy. So Japanese gastric cancer treatment guidelines, which was published 2021, is, and we go translation in 2023, and it shows that the gastric cancer, the curative treatment can be standard or non-standard. Standard gastrectomy involves either a total gastrectomy or a distal radical gastrectomy. Non-standard gastrectomy can be a modified surgery or extended surgery. Modified surgery, it is less radical surgery. We like to reduce it. In extended surgery, you try to remove adjacent organs as well. I'll come to that later. So non-curative surgery are divided into palliative surgery and reductional surgery. In palliative surgery, you try to palliate the symptom of the patient. You don't look at survival. In a reduction surgery, you try to reduce the tumor bulk and subject the patient for chemotherapy and try to prolong the survival also a little bit. So what are the standard gastrectomy indicated? It is indicated for clinically not positive and or T2 to T4A tumor. It is either total or distal gastrectomy according to the distance from the distance in the stomach and location in the stomach. And coming to the non-standard gastrectomy, it can be usually done for early tumor, CT1 N0 tumor, whether you do a pylorus obstructing gastrectomy or proximal gastrectomy, and local resections are not advised in stomach cancers. So extent of radical D2 dissection, I am not going to reiterate again. This is the nodal stations, which is described by the Japanese group. And we all know that. I am not going to, because candidates also answered very well. Total gastrectomy, distal gastrectomy, and the lymph node removal is slightly different. Distal, you try to preserve. Even for D1, you don't do station 2 and station 4 SA, which is short gastric. And in D1 plus, you try to preserve 11P also, that is proximal splenic artery node. And in D2 also, even for distal gastrectomy, you try to preserve 11D. So as you rightly pointed out, in 11, station 13 has to be removed if duodenum infiltrated. Station 10 has to be removed if the greater curvature involved, or station 4 is involved. Then station 14B has to be removed if station 6 is involved. So these are the thing we all of us know. So coming to surgical margins, the first thing we should know before deciding surgical margin is a Borman classification. Type 1, 2, the margin is different. Type 2, 3, 4, it's different. So type 1 and 2, it is okay to have a 3 centimeter margin. And type 3 and 4, we have to have proximal 5 centimeter margin. In case of esophageal involvement, more than 5 centimeter is not generally required. And if it's a T1 tumor, you can have a smaller excision with a gross margin of 2 centimeter. Coming to the minimal access surgery. So minimal access surgery is, I was really confused doing minimal access surgery till some years back, because the issue here is you are addressing a structure which is so spread out in the abdomen with 5-6 arteries supplying it, and you have to clear the nodal basins through each artery. And add on to that, you also had some membranes, which is omentum, bursa. So I thought it is going to be impossible to remove all these things. So, and we all know that we are doing laparoscopy to chopstick-like instruments. And how are you going to remove entire package of stomach with all nodes in laparoscopy? So I know many of my friends practice in Kerala, accomplished laparoscopy surgeons, and only for stomach cancer they open up. They don't do laparoscopies. So we can look into that. When you have a situation like this fisherman is trying to catch an octopus, which pretty looks like a spread out stomach and a lot of membranes on it, intact with the 2 sticks. Laparoscopy is going to be challenging like this. So let us look into the evidences which looked into evidence, the support of laparoscopy, use of laparoscopy for gastrectomy. So all started in Japan by Kitano in 1994. Then we have a lot of trials in early gastric cancer, which is Korean class 1 trial, JCOG trial. And then we have a LAP advanced for advanced gastric cancer, which is again Chinese trial. Then JL SSG trial in Japan, then class 2 trial. Then lately we have a lot of robotic trials as well. So I'll show you how these trials are showing you some information in a nutshell. So first thing, I like to look into early gastric cancer. Class 1 Korean trial. It showed in early gastric cancer, distal radical gastrectomy is accepted laparoscopically. Okay, good. It is non-inferior. Coming to class 2 trial done in China, which looked for the total gastrectomy, laparoscopic total gastrectomy. So what it found out, it is the short-term morbidity is good, but long-term survival, they have not reported, or oncological outcome, they have reported. And look at the JCOG trial, which again showed that laparoscopic distal gastrectomy is accepted as a standard of care. Coming to advanced cancer, class 1 trial, which looked into the laparoscopic distal radical gastrectomy, okay, equipoise. Then class trial, Chinese trial, class trial, both showed advanced equipoise. Then Japanese trial is also non-inferior for a laparoscopic distal gastrectomy. So the take-home message is none of these trials are showing advantage for or equipoise for a laparoscopic total gastrectomy for advanced cancers. So we have to be really careful in doing a total laparoscopic radical total gastrectomies, but it is not proven to be safe by most of the trials. But laparoscopic distal gastrectomy is safe. So again, coming to the other issues like omentectomy, bursectomy, then the trials have shown that omentectomy for T1, T2 tumors, no need to remove more than 3 centimeters away from the gastrocolic artery. And bursectomy has no role even for T4A tumors. And these two trials has actually made the job of laparoscopic surgeon very simple, because it is very difficult to excise the entire bursa by doing laparoscopy. So laparoscopic surgeons are more benefited by these two trials, where they could go ahead with the laparoscopic surgery. And coming to the lower third esophagus, the moment the esophagus is involved, we have to have a more than 3 centimeters. You have to have some kind of treatment to remove the knots as well. So esophageal involvement, according to Japanese surgeons, has been classified into less than 2 centimeters, 2 to 4 centimeters, and more than 4 centimeters. If it is less than 2 centimeters, you have almost no involvement of the mediastinum. If it is 2 to 4, you have a middle and upper mediastinum nodes are maybe involved. If it is more than centimeter, you have to really address the mediastinum in a proper lymphadenectomy has to be done with mediastinum. And again, follow-up. Where do you want to follow up the stomach cancer patient? We want to know the sequelae of treatment. We want to look for treatment failure, because it is very, very common for disease to fail in stomach cancer. And third, but not the least, is nutritional issues and deficiency, which I'll allude now. So the follow-up regimens, according to NCCN, for a stage 2 or 3, is to have a regular clinical checkup every 3 to 6 months, history and physical examination for 1 to 2 years, then every 6 to 12 months for 3 to 5 years. And endoscopy is if needed, you have to do, but in a limited gastrectomies, you have to do endoscopy more often. For a radical total or distal gastrectomy, it is not so often done. But CT scans are very important in stage 2, stage 3. You have to do CT scan every 6 months for 2 years, and then once in a year for 5 years. And then it is very important to watch out for nutritional problems. Suppose the patient will be having a lot of emaciation, he will be weak, and you do all investigations, you say, okay, you don't have any disease. But it's very important for us to look into the nutritional problems and rectify those. Otherwise, the patient's life will be miserable. So I tell a small incident where one of my biochemistry professors who diagnosed with stomach cancer came to us, and actually physiology professor came with who was my teacher. She came with the patient, and when I told I am going to do a total gastrectomy, she was shocked. She said, "How can you live without a stomach?" Because according to physiologists, the stomach is having a lot of secretions, lot of endocrine, exocrine secretions, the nutrition absorption, vitamin B12. So it's very, very tough for a physiologist to understand. Removal of stomach will be compatible with remaining life, but we surgeons don't care about this. But I think we are not completely right. We have to be really careful about the patient having issues post-operatively, and dumping syndrome, as the candidate discussed, is the #1 issue, and we have to find out, look carefully elucidating history. This usually happens immediately after surgery, but long-term patient can have B12 deficiency, calcium deficiency, iron deficiency. This has to be diagnosed. Otherwise, patient will be having a miserable life with all these sequelae. So it's very important to supplement if it is deficient. Vitamin B12 injection has to be given 1000 micrograms has to be given every alternative month. And having iron deficiency, you have to give ferrous sulfate, because ferric cannot be absorbed without acidity. It is absorbed in duodenum. So you have to give ferrous sulfate, and 200 milligram of element line has to be supplemented. And daily multivitamin tablet, which supplement calcium and vitamin D, is also essential because of the altered metabolism and absorption for the patient. So coming to how are we going to go ahead? This beautiful paper about various genetic classification of stomach cancer in 2014 September in Nature has actually told us the treatment of stomach cancer is going to be revolutionized. So again, there are two kinds of cancer, which is Epstein-Barr virus and MSI, which is susceptible to immunotherapy, and especially when you have MSI high, this patient is not going to respond to chemotherapy much. So this has been again proved by a landmark paper which looked into the outcome of patients who are having MSI high in looking into various past trials like MAGIC trial, and they accumulated data and looked into that, and they have found out that whenever MSI is high, the systemic chemotherapy advantage was much less. So I think in the near future, these considerations are going to be very important. And even now, American guidelines are asking for MSI testing for all patients, and NCCN guidelines are even advising to go ahead with immunotherapy based on some evidence to start with. But I don't think for us it is not mature for us to start with immunotherapy. But time will come very soon, maybe this ASCO or next ASCO, that immunotherapy is going to have a predominant role in adjuvant as well as in neoadjuvant role. And robotic surgery is coming in a big way. Now, maybe another 10 years, 15 years, everything is going to be revolutionized by AI also, where robots are going to do major surgery. And these two inventions, two directions, the role of genetic therapy, where everything is going to be genetic, and robotic surgery, where robots are going to, AI is going to replace surgeons, are a little worrisome for our surgeons. So let me end my talk by giving some take-home messages. I know that there is no point in giving take-home messages for people in an online meeting where you are already relaxing in your couch and watching this presentation. But again, you can take these messages. One is staging workup. So biopsy, CCT is very important. Diagnostic laparoscopy also is very important according to me, because we have found out that it's useful and we can avoid unnecessary therapy in 20% of patients. But EUS and PET are still optional. And coming to neoadjuvant recommendations, if it is more than T2 or N+, perioperative CT is desirable, especially float regimen. And adjuvant systemic treatment is given after primary D2. It has to be given because it has shown 10% at least survival advantage for patients. And coming to adjuvant RT, when you do a proper T2 dissection, and unless every node is positive, you need not give it. It is not going to be much useful. But in other scenario, you have to give it. And surgical principles, controversies I have gone through, and future direction is going to be immunotherapy and personalized treatment. Thank you very much for patient listening.
Thank you, Chandramohan sir. As usual, your talk was not only informative, entertaining as well, and I'm pretty sure it was able to hold the attention of all the attendees throughout the talk. Thank you, sir. Now I invite our EC member from West Zone, Dr. Manish Pandhare, himself a very complex GI surgeon, and he'll be going with the examiners the questions that the attendees have for our experts. So now the examiners become the examinees. Over to you, Dr. Manish.
Yeah, thank you, Dr. Srijan. And it was a wonderful time to attend the whole session. Thank you to all the examiners and moderator today. There are a number of questions, numerous. I think we cannot have time to go through all of them. But again, thank you, Srijan, to concise them and compile them into a brief. The first one is that, as we saw in the first case, which Dr. Caleb presented, the patient had a complete pathological response after neoadjuvant therapy. There was a brief discussion on this as well, but the question here is that how do we decide on de-escalating treatment in such scenarios, given the fact that we know that the float regimen, which is used more often now, can also be a toxic regimen. So is there a way that we can avoid therapy in cases where we have achieved excellent response, like a pathological complete response? To any of the
Who's
three.
supposed to answer? Is it question to us?
I would keep it open, sir. I mean, you, Dr. Caleb, Dr. Pradeep.
Nobody's answering, I will answer. See, this is a very tough question, difficult question. You can approach it in two ways. Number one way, the patient had a disease has gone. So what's the need for further chemotherapy? And the other way of looking at it, the patient has responded to a good treatment regime. And why don't you tap the advantage of the regime again? So these are the two questions. And I feel that stomach cancer is a very aggressive disease. And even with all the treatment, actually, even you see survival of like 45% in trials, but actual survival in the country is something like 20 to 30%. And you should leave no stone unturned in managing the disease with the most radical treatment. If the patient can tolerate, you have to complete the treatment. Otherwise, patient cannot tolerate, you can skip. That's my take on this issue.
So do you think, of course, we take it, that means that we should go ahead and complete therapy in this scenario? Is that what you mentioned? So going forward, do you
I feel
see?
so.
Yeah,
Absolutely.
absolutely.
I don't have any strong evidence.
There is no strong evidence, but going forward, maybe this is one area which should be rather further evaluated, whether a de-escalation is an option. But I think it has to be done in a trial scenario and in routine practice, as Dr. Chandramohan.
So what do you think, Manish? What is your opinion? Manish, what do you think?
I absolutely agree with you. We should continue. If the patient has received a total neoadjuvant therapy, that means 8 cycles of a FLOT or a 6 cycles of a MAGIC regimen, then we may avoid any further therapy in that scenario. But if we have used only 4 cycles or 3 cycles as a standard perioperative regimen, then we should complete the remaining cycles at the end of even if there is a pathological response.
Dr. Manish, what about if the surgery is not appropriate? I mean, if it's, let's say it's not a D2 dissection, if it's a D1 dissection, then there would be definitely a role of escalation of therapy.
Absolutely. It would also depend on the pathology report. As of now, the current recommendation, as we know, is that we should go for a chemoradiation, adjuvant chemoradiation, instead of only adjuvant chemotherapy in a suboptimal lymph node dissection situation. There is hardly any role of going in again and doing another surgery for just lymph node clearance, depending on how much lymph nodes. But I think, yes, in that scenario, we should. Okay, and then going to the second question, which was also discussed in one of the case, when there is a tumor which is bulky at the antropyloric region, which is which is kind of maybe involving pancreatic head or maybe just the capsule of pancreas, which is more common than direct invasion into the full parenchyma. How do one decide between proceeding with surgery or abandoning the procedure first? Or if we are proceeding, then would a limited pancreatic capsular shaving or a head coring should be an option, or should we go ahead with a radical resection like Whipple?
Yeah, so in this setting, I think we need to first look at whether the patient has received chemotherapy or not. If the patient is being upfront operated for such a patient, then probably we should give chemotherapy and reassess. If the patient has already received chemotherapy, we need to look at how much of the pancreatic head is involved. If it is, like you said, I think generally it's only the capsule which is involved, in which case, we can usually shave off part of the tumor. If not, if it is deeply infiltrating, I think we should call it as an unresectable case. And Whipple is generally avoided for such a case because the prognosis will not be really great.
That's right.
All right. I think absolutely what you mentioned is absolutely true. One just thing additionally, if I can mention, is that there is something called as other incurable factors which are defined when we are planning any kind of an extended surgery for gastric cancer. So we have to be sure that the lymph node disease is not extensive. There should not be any spot of bother in the peritoneum, not even a single speck, etc., which are other factors which are also, or a young patient with a signature histology. Basically, all the poor prognostic factors, we should not go ahead with an extensive resection, and only limited disease we can localized limited infiltration into the pancreas, and the rest of the factors being okay can be a exceptional indication for a radical surgery. In that same line, the role of surgery when there is an oligometastatic disease, whether we do a radical curative resection, something like a cytoreduction. There was another question in the chat box that if there is no metastasis, but just the cytology is positive, then how do you treat these cases with curative surgery? What's your take, Dr. Pradeep or Dr. Chandramohan or Caleb? Maybe briefly, all three of you can put your viewpoint, because there may not be a single right answer to this question.
The cytology is positive. I would think that patient should go for neoadjuvant chemotherapy. Following that, when we do surgery, probably we can think of doing a cytotoxic surgery with HIPEC that time. But initially, as sir also mentioned, Professor Chandramohan mentioned that initially the patient should go for chemotherapy, not surgery upfront. So that is one. About oligometastatic disease, I don't have an experience, so I would request Dr. Chandramohan to answer that.
Dr. Caleb Chandramohan.
Yeah, so actually, when you look at a disease, the most important thing to go ahead with the treatment is looking at your survival. So with the radical treatment, with the non-metastatic disease, if you're having some 20-30% survival, so by going ahead with a radical surgery for a metastatic disease is a foolish idea. But at the same time, when you look at the Japanese, they still advise surgeries for limited metastasis. And one more thing which has added up in armamentarium is HIPEC, which is become handy for a HIPEC surgeon when you have peritoneal disease is positive. But even for the HIPEC guidelines or the Chicago protocol is not advising HIPEC except in the diagram for a metastatic peritoneal disease. So my take on this issue is, as if now, especially for a candidate appear for exam, the answer for this question should be in a metastatic gastric cancer, let it be peritoneum, let it be other organs, the answer is no radical surgery.
Dr. Caleb, you want to add something?
I think I will agree with Dr. Chandramohan. As per the exam point of view, I think what he said is right. But maybe a small limited oligometastatic disease, provide the general condition of the patient is good and the disease biology also is good, we may consider, but it's strictly restricted to a minuscule population.
All right. So I think from exam point of view, especially, or even rather in clinical practice, it would be safe to say that for all practical purposes, it's a stage 4 disease and palliative therapy only should be considered. However, exceptional scenarios, this may be used, and some of the Asian centers have shown encouraging data with this aggressive modality, but the case selection has to be extremely very, very well selected. The fourth question is about the margins. There was a brief discussion based on the margins and how do we decide the histology and then the margins, whether you would go for additional margins or larger margins in a particular scenario. And how do you achieve a big margin at G junction? Is it always a must to go 5 centimeters into the esophagus, or would you accept a negative margin or a lower length of resection margin, like a 1 centimeter margin in the proximal site?
Yeah, I mean, let me answer. 1 centimeter proximal margin is a highly dangerous affair. Why? Because when you have 1 centimeter proximal margin, the chance of microscopic spread, especially in a type 3, type 4 cancer is very, very high. So your surgery may be futile. And if you do that, actually 1 centimeter is the margin you are attempting in a patient. When the final report comes, invariably, it may be positive. Umpteen number of times it has happened to me. So it's very, now and we have analyzed our results of this proximal margin and we have found out that this seriously affect the recurrence and survival of the patient.
But then now, in that case, would you recommend that if you do a frozen section evaluation on table in all these cases?
Frozen section is desirable. It solves issue. But even in case of frozen section can tell you whether there is no disease at all. It won't tell you how much centimeter margin is there.
True.
It's a good method. It's a good method, and microscopic can be picked up if you have good frozen section facility. But your aim should be not relying on frozen in a positive margin, but you have to have a recommended margin which should be more than 3 centimeter in early disease and nearly 5 centimeter in advanced disease. But nothing less than 3 centimeter in a Borman type 3-4 should not be accepted.
All right. And then coming to the last question that we will discuss is total mesogastric excision the same as what is called as the standard D2 gastrectomy, or is there any difference?
Yeah, so I have some information because me and Dr. Subramanian Rao have extensively visited some meetings where Chinese surgeons were presenting. And they believe on some concept, they even for rectum, like and colon, they do mesocolic excision, mesorectal excision, and now this concept is slowly going into the stomach as well. So what they propose, the cancers other than lymphatic spread, hematogenous spread, this cancer also spread via the membranes. So it's very important to go and excise the entire membrane, and they said that there are 5 pathways of spread, and one is the 5th pathway is via membranes, where the entire membrane has to be excised in toto, so that the radicality is preserved and outcome is good. And they also look for the trifurcation, the tri-membrane junctions, etc. So I think it is a Chinese concept and it is different from D2 gastrectomy.
Yes, absolutely. And I think the reason that it has not become popular as compared to a mesopancreas excision or a mesocolic excision or a mesoesophageal excision is because it is technically very difficult to define these envelopes or boundaries that they have tried to define. So it's not popular and it's not the same as a standard D2. It is slightly more radical than D2. That's what the message is. So I think with that, Dr. Srijan, can we end the question answer session, and over to you.
Thank you, Dr. Manish Bandare. Very well executed Q&A from our experts, and I think we found answers to most of the queries that have been put on the chat box. This brings us to the conclusion of our webinar today. I would like to thank all the examiners for putting a lot of preparation into this masterclass. Many are not aware there's a whole discussion that happens on which cases go. There's a to and fro between the examiners, and it's a lot of effort that they put before we come here. Actually, it's the students who come absolutely unprepared, and which is a good thing for them. So thank you, Dr. Caleb, for making that effort of making the presentation, as well as Dr. Chandramohan and Dr. Pradeep Jaiswal for their valuable inputs that went through the cases. Thank you, Dr. Chandramohan, for that excellent talk with all the recent evidences. I think any student might be able to go capture all the relevant information that they need, at least for their exams. Thank you, Dr. Manish Bandare, for a very well executed Q&A. And last but not least, thank you, the examinees, Dr. Varun Joshi and Dr. Sandeep, for volunteering to participate in this, and hopefully you gain something out of it. For all the other participants, thank you for logging in. We'll be back in another 2 weeks with another webinar. With that, a last thank you would be to the IASO leadership, who has been backing us up all throughout the last 3-4 years in conducting this IASO Masterclass, which has been helpful for all students and faculty across IASO. Thank you so much. Good evening and good night.
Thank you.
Thank you, Dr.
Thank you.
Well done.
Thank you, Dr. Caleb.
Thank you. Well done. Yeah.
Thank you, sir.
Thank you, sir.
Specifically, SVS Dev and Rudra, I think, need a pat on their back for allowing us to do this and tolerate.
Thank you. Good evening, Dr. Rao. Good evening, all the faculty. I really enjoyed. It's a wonderful session. Dr. Manish, Dr. Chandramohan, Dr. Pradeep, Caleb, good to see you all.
Thank you, sir.
And all credit goes to Dr. Rao and Srijan and all the faculty. We really enjoyed the session. Thank you very much.